This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Bouchard, of Cardiology Specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
So welcome to our podcast on LP(a) or lipoprotein(a), a biomarker for heart disease and stroke. And with us today, we're fortunate to have Dr. Leslie Cho, who's a professor of medicine, as well as interventional cardiologist and director of the Cleveland Clinic's Women's Cardiovascular Center. She's also section head of preventive cardiology and rehabilitation, chief quality officer, again, at the Department of Cardiovascular Medicine at the Cleveland Clinic. So, Leslie, thank you very much for taking the time and helping us on this very interesting topic.
Thank you so much for having me. It's my pleasure to be here with you today.
Thank you, Leslie. So not too long ago, we did a segment with Dr. Steve Neeson, who is your a very, very important collaborator for many years. I've worked together and your esteemed colleague, and it was on statin and supplement. And it was very, very interesting. The statin, of course, are so important. We've been treating our patients both for primary as well as secondary prevention, statin for over 30 years. Usually, we can make quite an impact, particularly when the patients are taking the medication. It was maybe reducing the chance of stroke or heart attack by 30 to 40%. But there's still a number of patients, 60 to 70% of our patients that are still at risk for a heart attack, for a stroke, for closing their stent or closing their bypass. So today, here we are, we're talking about this new, so-called new for a lot of people, lipoprotein(a). I'd like to ask you, what is lipoprotein(a)? How does it compare to LDL, the bad cholesterol? Is this like the bad and the ugly?
That's a great way of putting it. So lipoprotein(a) is an LDL-like moiety. It is, it's been known about since the 1960s. It's not anything we eat or, diet or exercise. It's something that is genetically inherited. And it is an important and a very potent risk factor for development of premature heart disease, stroke, and calcific AS. There's been multiple studies looking at its important role in primary prevention population. We have great epidemiological studies. We have great genetic studies. We have Mendelian randomization studies that have consistently shown its effect in terms of premature heart attack, stroke, and calcific AS.
So what is the connection between the lipoprotein(a) and this atherogenesis or this kind of increased risk of stroke and heart attack?
Yeah, so LP(a) is both prothrombotic, proatherogenic, and pro-inflammatory. So it really is a bad player. So there's been studies. Our group has published a study looking at intravascular ultrasound. People who have elevated lipoprotein(a) have more plaque in their intravascular ultrasound. They have more atheroma. People who have elevated LP(a) have an increased risk for having more inflammation. And we all know the important role of inflammation in cardiovascular disease. And then LP(a) is, if you look at the compound, it looks a lot like plasminogen. And so it's prothrombotic as well. And so people who have elevated LP(a), they unfortunately have the risk of having proatherosclerosis, pro-inflammatory, and prothrombotic risk.
How do we measure LP(a)? Is this just kind of a blood sample? How do we measure it? And actually, who should we be measuring in?
That's a fantastic question. So LP(a) is a blood test. We should be measuring it. The European came out with this guidelines on who should be getting LP(a). And I think the idea is very sound. We should be measuring LP little a at least one time in people who have history of premature heart disease in their family, people who have had heart disease diagnosed at a younger age, and then people who continue to have events. So people who've had a heart attack, people who've had a stent, who continue to have further events on therapy for LP little a.
So this is interesting. In fact, when I'm seeing a patient and they come with their children, a lot of times they've had, kind of their heart attack or stents in their 40s. I'm looking at their kids, and then potentially we could not only influence, make a difference with our patient, but potentially with their children as well. It's so-called primordial prevention, I guess.
Absolutely. That is a fantastic point. You're right. We should be measuring it in those patients' children, because you can really make a tremendous impact on that patient population. This notion of primordial prevention actually is something that's near and dear to my heart. One of the problems with LP little a is that, sometimes people know about it, they don't measure it because they're like, there's nothing we can do. But there's some data out there that shows that if you measure LP little a and that's elevated, that you can impact patients in terms of healthy lifestyle, so they can be exercising more, eating better, and perhaps getting these patients LDL down to less than 70 can have an impact on their cardiovascular event rates.
So not so much that the healthy lifestyle or the statin would lower the LP little a, but they will influence maybe some of the other factors of atherogenesis, right?
That's absolutely right. I mean, unfortunately, LP little a is something you're born with. And so whatever number you have, it really is static. Maybe after menopause, it goes up a little bit, but for most people, it's fairly static. And so you can't exercise it away, you can't diet it away, but you can certainly lower your other risk. For example, you can lower your risk for high blood pressure, you can lower your risk for diabetes. You obviously should not be smoking and maybe exercising, just getting everything else in alignment.
Right, good point. So let's say we have an elevated LP little a. Before we start talking about some of the studies that you're conducting and that are currently undergoing to really target LP little a, do we have any mechanism to lower, LP little a? For example, I thought that it used to be that we thought we would lower LP little a with niacin, but when we look at the clinical trials, we had no impact whatsoever.
Absolutely, you're right. I mean, niacin at the highest dose does lower LP little a by about 30%. It really had zero impact on cardiovascular outcomes. Estrogen therapy, hormone replacement therapy also lowers LPA, but it again had really little outcome. What did have a benefit in the LP little a population, especially in postmenopausal women, was aspirin. Being on aspirin therapy did lower events. There are, for example, it's very interesting that you bring it up, but there is one thing that does lower LP little a, that is PCSK9 inhibitors. And when we look at Odyssey outcomes, which is alirocumab, PCSK9 inhibitor, or evolocumab, which is Repatha, in 4EA, we see that the PCSK9 does lower LP little a by around 25%, but it has a pretty dramatic reduction in absolute event rates in patients with who are on PCSK9 inhibitors who have elevated LP little a.
That's very interesting. So what's very, very interesting now is what's coming up. Because finally, I feel like we're going to have a treatment for elevated LP little a. This is quite exciting. I know you're very, very involved, with some of the clinical research ongoing. You're enrolling patients. And so can you tell us a little bit? It seems like there's at least, two that are being studied now.
Absolutely.
Two new treatment. Go ahead.
Yeah, absolutely. There is one that it just finished enrolling in their phase 3, which we are privileged to be part of and leading that effort at Cleveland Clinic. Steve Nissen is the the overall study chairman. I'm one of the co-PIs. It's called LPA Horizon. So it is elevated Lp(a) greater than 70 milligrams per deciliter in patients with history of myocardial infarction. It is around 8,000 patients. We finished enrolling in 2022. We started that trial right before COVID. It finished enrolling, thank goodness, and hopefully we'll get a readout on that study soon. The other trial that's just started enrolling is the Amgen's small interfering RNA or siRNA olpasiran, Oceans A. That is going to be enrolling patients with elevated Lp(a) greater than 90 milligrams per deciliter with a history of MI or a history of coronary artery disease with a revascularization history. That is going to be enrolling around 6,000 patients. That's a phase 3 study. They're going to be enrolling. They just opened that trial for enrollment December of 2022. And so we'll see how that goes. There is another very exciting drug out of London and Germany from a company that we've been fortunate to partner with called Silent Therapeutics. It is another siRNA lowering of Lp(a). And it is exciting because siRNAs, you inject every 3 months to 6 months. The exciting thing about the trial that Steve and I are doing, which has finished enrolling, the LPA Horizon, is an ASO, which is antisense oligonucleotide, pelacarsen. It's a injection that you inject every month. So, we're going to have very exciting news, and we'll finally be able to answer that very important question in an era of high intensity statins and PCSK9 inhibitors. Does lowering Lp(a) reduce the risk?
Right. So these are going to be outcome driven. And we won't find out until probably 2024, maybe for your study horizon. Is that right?
I think most likely the outcome trial for LPA Horizon, I would imagine, will be even 2025. Right. Because the follow-up is about 5 years. And so we'll see how that goes. But this is an exciting time because all of us who have studied the Lp(a) for years, we kind of had no treatment. And finally we get to know the answer to the question, does lowering Lp(a) work? So
this is for outcome data, but we know we have some phase 2 studies, determining how effective these drugs are in lowering Lp(a), right? They're pretty powerful.
Very powerful. The drug, the antisense oligonucleotide, pelacarsen, that lowers Lp(a) by anywhere to 70 to 85, 90%. The siRNAs lower Lp(a) by 80 to 90%. These are powerful drugs. Now, there is apheresis. You know how cumbersome apheresis is, and that's
like dialysis.
Exactly. A dialysis for cholesterol that has been approved in Germany for patients with Lp(a), but that's not something you can, that's not for prime time. That's not something that we can do for everyone, because Lp(a), having elevated Lp(a) affects around 20% of the population.
Right. So in the future, Leslie, let's say we care, we look like 5 years from now. How do you see integrating, Lp(a), its measurement and its treatment in clinical practice of cardiology?
Yeah, that's a fantastic question. I think the one important thing is that there are some cardiologists who, even today, they've never heard of Lp(a), and they don't believe in the role of Lp(a). This is not a belief system. It is it is science. It is very evidence driven. And I think that having people, getting an LP(a), hopefully one time at least in your life, will be a standard of practice. And people come in and they get their cholesterol level checked at age 20 or 25. Hopefully they'll get their LP(a) checked too. And for people with history of premature CAD, their children will have their LP(a) checked. Their siblings will have their LP(a) checked. The other sort of big push is to standardize how the LP(a) assay is done, nanomoles per liter instead of milligrams per deciliter. Sort of standardizing the assay, I think that's another important factor. And then really sort of thinking about these risk factors in the whole field of cardiac risk factors. So not alone, but in the field. You think about your blood pressure, you think about your cholesterol, you think about your diabetes risk, you think about your obesity risk, family history, smoking. And then, of course, within that family history is LP(a). Within that history of cholesterol would be LP(a). And then for people with, depending on how these outcome studies would go, perhaps using an LP(a) lowering agents for patients with established CAD.
Well, very well said. And I think the future is bright and just getting brighter. Thanks to your great work at the Cleveland Clinic. I mean, we know that you've always been in the forefront of clinical research as well as clinical care. And I know that for all of us cardiologists in the U.S., we measure the care of our patient and always ask, how do we stack up, with people at the Cleveland Clinic? So, Leslie.
Oh, that's very kind. Thank you for your kind words. Thank you. That's very generous and kind.
Leslie Cho, thank you very much for taking time out of your schedule and helping our patients as well as our residents and fellows, in cardiology and making the cardiology world just a better place to be.
Thank you so much. Thank you for having
me. Thank you, Leslie. I appreciate it. Bye-bye.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.